gente también La gente también dice, oh, cuando el enfermero me hace las preguntas, me toma con tanta frialdad. Después llega el médico y ¿qué es lo que pasa? La gente siempre dice, el médico llega y lo primero que hace es ponerse en la computadora y nunca hay un contacto visual. Y tal vez a veces nos tenemos que guiar como lo que el doctor quiere, no lo que yo quiero, no me deja dirigir esta cita, ¿verdad? Entonces se sienten como que no son escuchadas y hay dos historias que se me quedaron muy grabadas, ¿verdad? Que escuché de una sobreviviente. Ella dice que fue golpeada por su esposo, entonces tenía dolor en la espalda, fue al médico y el médico simplemente hizo una revisión encima de la ropa. Entonces ella después se dio cuenta que su espalda estaba toda llena de moretes. ¿Qué pasó? Se perdió la oportunidad de darles ayuda a esa persona. Esa persona se vino con un gran desánimo, ¿verdad? Porque dijo, bueno, si la persona en la que yo estoy confiando mi salud no está poniendo atención, entonces ¿a dónde debo de ir? También hubo otra historia muy impactante, que fue una persona que fue violada, ya había sufrido violencia doméstica por 20 años, esa noche fue violada y bueno, entró en una crisis, tomó medicamento, se quiso suicidar, fue al departamento de emergencia, violada, en una crisis, hicieron exámenes de orina, permitieron que el abusador estuviera siempre presente y nunca se dieron cuenta en esa conexión. ¿Por qué una persona viene en crisis y por qué encontramos semen en la orina? Esa persona se sintió muy desilusionada del sistema porque nadie estaba tal vez poniendo atención o preparado para ver esas señales, ¿verdad? Entonces yo creo que son demasiadas las historias y tenemos nosotros como promotores a veces que trabajar un poquito para poder animar a la gente que vayan a buscar esos servicios, ¿verdad? Entonces queremos trabajar con los sistemas de salud también para ver qué se puede hacer para poder como llegar a un camino donde podamos lograr esa sanación o dar esa atención a la comunidad.
Gracias, Paula, por compartir la perspectiva. Entonces, para resumir, es importante que haya poder compartido cuando la comunidad, los pacientes van a ver a su doctor y también mejorar el asesoramiento y hacerlo en una forma confidencialidad, ¿verdad? Proveer la confidencialidad.
Exacto.
Oh,
Am, Nomás quiero saber si todos pueden escuchar esto en inglés. I just want to make sure that everybody's able to do the interpretation if anybody needs any help. Okay, perfect. Thank you.
ok. Ahora, Rosa María, como promotora de salud de violencia doméstica, ¿sí nos puedes compartir qué has escuchado en la comunidad de las sobrevivientes del impacto que la violencia doméstica tiene a la salud de los niños, a la sobreviviente cuando no reciben información por su doctor?
Sí, claro que sí, Erika. Definitivamente hemos escuchado que hay un impacto tanto en la sobreviviente como en la salud de los niños. Cuando un proveedor de salud o su doctor no les brinda información necesaria o suficiente información, la sobreviviente no sabe hacia dónde dirigirse, ¿verdad? Esto es parte de lo que la comunidad nos ha compartido. Dónde encontrar apoyo, no sabe dónde encontrar ese apoyo o dónde encontrar recursos, y los niños también pueden sufrir la falta de información y verse reflejado en su salud. A veces las sobrevivientes no están conscientes de cómo la violencia doméstica afecta a sus hijos. Por eso la importancia de la educación sobre la violencia doméstica a las sobrevivientes. Los niños también son víctimas y también necesitan apoyo. Su salud es afectada de muchas maneras. Puede cargar con una serie de problemas de salud física, mental, incluyendo deterioro del desarrollo social. Pueden dañar la autoestima de los niños, emocional, cargando con ansiedad, depresión o estrés también, y cognitivo, afectando su memoria del desarrollo o el desarrollo de su lenguaje. Lesiones o incluso problemas de salud a lo largo de sus vidas, adoptando conductas de alto riesgo como fumar, abuso de alcohol o de otras sustancias, o incluso adoptar el comportamiento abusivo. También convirtiéndose en personas que abusan en sus vidas adultas, ya que son comportamientos aprendidos, es decir, lo que ellos ven lo pueden repetir, ¿verdad? Porque lo aprenden. Por eso la importancia de que su doctor les brinde toda la información necesaria y posible para que tanto la sobreviviente como los niños
Rosa
puedan...
María, disculpa, ¿le puedes un poquito más despacio para el intérprete, por favor?
Ah, sí, claro, perdón.
Gracias.
Decía que es importante que el doctor les brinde toda la información necesaria y posible para que tanto los sobrevivientes como los niños puedan obtener la atención médica adecuada y educación necesaria, dependiendo claramente de la situación del caso de cada persona. Su doctor puede ser uno de sus mejores aliados, ya que cuando un sobreviviente asiste a una visita médica, puede ser una gran oportunidad para brindarles toda esta información.
Gracias, Rosa María. Entonces, para resumir, es importante que haya una forma de educación para hacer la conexión de cómo la salud está siendo impactada por la violencia, no nomás para los niños, sino también para los padres, para los sobrevivientes, ¿verdad? Porque pues como padres estamos haciendo lo mejor que podemos con lo que sabemos. Y si hay oportunidades de proveer esa información, esa educación, creo que sí está bien recibida por padres especialmente. También es importante dar el recurso, como dices, dar la información para que uno sepa dónde obtener ayuda si es que la necesita, ¿verdad? Tener los recursos disponibles y saber dónde están esos recursos, ¿verdad?
Correcto.
Ok, bueno, muchas gracias. So now we're going to continue speaking about cues, the cues model. This is a recommendation. It's a evidence-based intervention that we are trying to promote in the medical sector. It was something that was created years ago that has been shown to enhance the screening process for intimate partner violence. Next slide. So we know that due to this evidence-based intervention, we learned that research has shown by this intervention that victim survivors who talk to their healthcare provider about abuse were 4 times more likely to use an intervention and 2.6 more times to exit an abusive relationship. What I've learned and what I've researched on is that also those who get screened for intimate partner violence, only about our traditional way of asking those 3 questions, only about 25% of those disclosed. So what happens with the 75%? What happens with the rest of those? So those are some things to keep in mind. Next slide. So what has been shown to work is, as we know, as our promotores shared, everyone goes to the doctor at least once a year, either for themselves or for their children. And so that's an opportunity. Healthcare responders can serve as a lifeline. And we talked about, our promotoras talked about, Rosa Maria talked about providing that education about intimate partner violence and where to get help. So offering that universal education and making the connection of how domestic violence can impact someone's health, and to provide that information to everyone, regardless if there's disclosure or not. So the way to do this is by providing universal education to everyone. And so with the CUES model, one of the tool that is used is it's a safety card, and there's different adaptations of the safety card. There's some for pediatric care, there's some for primary care, behavioral health, there's some for the homeless population for the LGBTQ community. They've been adapted in English and Spanish. Recently, I've seen the one that's being used through First Five to address toxic stress among children. And so that's another form of education for parents. Next slide. So in the chat, I actually put an example of what of the general safety card so that you guys can take a look at that if you have never seen it. So this evidence-based intervention provides an opportunity to share power with the safety card by providing the education. Also, it decreases incidents of intimate partner violence, increases knowledge of local domestic violence resources, and there's a high likelihood that it can be shared with family and friends. And there's an appreciation of the opportunity to discuss safe relationships by service providers. Next slide. So this model, this intervention, it's not about having the patient disclose. It's not having the patient give you something first in order to be able to provide the resource. It actually builds trust and connection with the patients and with that resource, and be a resource to make that connection with the domestic violence agencies sooner rather than later, before things get harder in that relationship. Next slide. So this is what Q stands for. So there's 4 little sections on this intervention. So the first section is confidentiality, going over the limits of confidentiality and being able to speak with the patient alone. That means going over that if you're a mandated reporter or not, making sure that it's safe to have this conversation, making sure that the person that's causing harm is not in the room. And sometimes we're not able to do that. And so making sure that we document that and making sure that we're able to do it next time, if not at that visit or even follow up. And then the universal education piece is providing that resource, that safety card, and making that connection about healthy relationships. And also there's an empowerment piece, right? That these safety cards can be shared with a friend or a family member that may need them. And then the support piece, because this is a conversation, there might be a disclosure. And if it does happen, making sure that you're offering harm reduction strategies and that you're making a referral to an advocacy service, to a domestic violence agency. And then if a domestic violence is not disclosed, saying, well, this is still a resource, because we know that relationships can change, and giving them that little safety card to take just in case something changes. Next slide. So Q's is a paradigm shift. This approach is not screening for intimate partner violence, but providing that universal education. It's not trying to identify who's a victim and who's not a victim, and it's not adding more work to what you're already doing, because screening is part of that section of getting the history of each patient. So this approach strengthens the work that you're actually doing, like that whole person care, right? And then it's a prevention, it's an early intervention, right? Because by the time they come to a domestic violence agency, they might already be in crisis. And it's providing access and resources for all patients, not just to the ones that disclose. Next slide. So here's an example of one of the panels in those safety cards. This one's specifically talking about healthy relationships, right? So this one says here, how's it going? Everyone deserves to have partners listen to what they want and need. Ask yourself, is my partner or the person I am seeking kind to me, respectful of my choice? Oh, next slide, I'm sorry. Oh, I'm sorry, go back. I am in the right slide. So as I was saying, it makes the patient critical think and ask themselves, is my partner or the person I am seeing kind to me and respectful of my choices? Is my partner willing to talk openly when there are problems? Does my partner give me space to spend time with other people? If you answer yes to this question, it sounds like you have a supportive and caring partner. Studies show that being cared for by the person you are with leads to better health, a longer life, and helps your kids. So this, for example, this panel section here can be read with the patient, or once you have the patient waiting to see the provider or or to wait for test results, or while you're like typing in the computer, they could be reading this card. And then you can follow up saying, do you have any questions? Right? And you can have them take a look at it and say, well, this is something that we started giving to all families in case they need it for themselves or for a friend. It talks about safe and healthy relationships. Take time to read it now. Take time to read this panel. How's it going? And then let me know if you have questions or what are your thoughts around it. So it invites that opportunity to share that power and to have a dialogue rather than like asking those 3 questions and getting that yes or no answer. Next slide. And what's really important is if a referral is needed, making sure that you know where to refer, making sure that you as a provider know how to address that, right? To have more of a coordinated care. So it's important to know who your resources are, because as you can see here in the script, one of the things that you can say is, if you're comfortable with this idea, I would like to call my colleague at next door. They have helped many people who have been in similar situations if domestic violence is disclosed, right? Knowing what to do when disclosure does happen. Next slide. So now we're going to hear the clinic perspective and the survivor perspective, right? We're going to hear from Erica Monasterio. I want to ask first, because her clinic has been one of those places that has implemented and incorporated cues, tried out cues, right? And so we want to hear, and I want Erica to share, you know, what that was like. So the first question that I have for Erica is, what is your current protocol for intimate partner screening and positive disclosures?
So we use the safety cards and do a cues intervention on all new patient visits, all annual visits, and then when issues arise during a visit. So it's not like, you know, trying to use your radar to figure out whether somebody's having relationship issues, but so it's just universal for everybody. But if issues do come up during the visit, then the safety card is there to help the provider really discuss it. We have a we use Epic as our, so at my clinic, it's called Apex because it's part of the UC system, but we developed a smart phrase that includes language that the patient did not disclose or the patient affirmed, because we're not using a screener. So you can't say that the patient denies, you know, that being hit, slapped, etc. But you can say that they did not disclose it, or that they affirm that they've had these experiences. In terms of disclosures, you wanted me to talk about what happens with positive disclosures as well? Yeah. So in terms of disclosures, it's an adolescent and young adult clinic. So we have sort of a different protocol for under 18 and 18 and older. So with under 18 patients, there are different considerations related to child abuse reporting. So, you know, the script, the approach, explaining confidentiality is a little different than it is for people who are 18 or older. And in addition, there are adolescent-specific programming in domestic violence organizations. So the referrals go to, and the relationships are with organizations that have adolescent-specific programming. And then for the over 18-year-olds, we utilize adult resources with additional support. When there is a disclosure, it really depends on the tenor of the conversation, the relationship. Is this somebody new who doesn't really know the provider and might be open to seeing somebody else? Is this somebody that the provider has a long relationship with and the patient might feel more comfortable just talking with them? So that is the patient or client's choice, whether they want to meet with a social worker to have more of a discussion or whether they want to just talk with their provider. Either can provide that warm referral. So you don't have to see the social worker to get the referral. You can be with your provider, and that connection to an agency, a person at an agency, can happen in that context, or it can happen after meeting with social worker. And we also have a local resources information sheet. The cards, I always have cards on my desk. The cards are great. There's all of them on the back cover have resources, national resources. You can add on, with a sticker or however you want me to do it, local resources. But what we do in our clinic is we just have an additional sheet with local resources that the client might want to avail themselves of, just to make sure that everybody has access to information.
Well, that's awesome. Well, thank you, Erica, for sharing that. Another question that we have is, are you able to share challenges and barriers that your clinic experienced implementing the use of the safety card or the universal education?
Yeah, so one issue is training. It's relatively easy at the onset to kind of get everybody trained. And what we did was we trained all of our staff, front office, back office, providers, everybody who was working in the clinic initially. And because it's a hospital-based outpatient clinic, we do have a lot of trainees rotating through. So all the interns came once a month, and there's a series of trainings for them anyway. And so this was built into the adolescent relationship abuse training, was using this intervention. But it's hard to get new staff trained. There's turnover. We ended up having a couple of champions for using the CUES intervention who mostly did one-to-one and continue to do one-to-one training during onboarding for new support staff, because it's just, there's not a mechanism to train them otherwise. But there's a whole lot of other issues they need training in, particularly adolescent confidentiality. So we just added it to that series of trainings. And again, a lot of materials that they could read in addition to having a conversation about it. Another big issue is confidentiality. It wasn't so much an issue in our adolescent and young adult clinic, because confidentiality is such an issue that we kind of have it down. But when patients come with their children, we didn't really have a plan for where their children could be, and nobody really wants to talk about their relationship issues with their 6-year-old sitting in the room. So figuring out how to really provide a private space to meet with the client without children. We had already kind of worked out the friends and partners and parents issue, but just really reinforcing that this is part of a confidential conversation. Time, disclosures, when there are disclosures, that takes additional time, but so does any other issue that might arise. I mean, we don't not do a pregnancy test because if the person's pregnant, it's going to take more time, or we don't not diagnose pelvic inflammatory disease because it's going to take time. So, we just tried to frame it that way, that this is, when you're looking at relationship issues, it's part of your differential diagnosis and you need to develop it. And in order to develop your differential diagnosis, that you have to take the time. Social worker wasn't always available for follow-up, and people did not come back when we would give them an appointment for follow-up. So our solution for that was to just, when the social worker isn't available, the provider or as backup, the clinic nurse would engage in further intervention. And sometimes, even though we had an agreement and a backline number that we could reach the DV agency that we had primary partnership with, that phone number didn't always get answered. And so we sometimes had to sit with clients and have them use the 24/7 phone number for the agency in order just to get that connection, get the foot in the door. So we prefer not to do that, because a warm referral is like, I know this person, I can vouch for them, you trust me, I trust them, let's share that trust. But when you can't get through, you can't get through. And then competing priorities. There's lots of things that need to get done, and there's always new mandates and new things to talk about. And ACEs screening came after this, so integrating that. But it was a pretty seamless integration because there's such related issues. But so there's just that, competing priorities. And then finally, some pushback that we had, especially in an academic center, about using validated screeners, this push to use validated screeners. And so we would just go back to the evidence, which is Erica presented earlier, that people do not, it's a very low disclosure rate with screeners, with question answer. People have an opportunity, people want to talk to their healthcare providers about this. And when they have an opportunity to talk about that, when they're ready, when it's their agenda, they will avail themselves of services. And so just going back to that rationale and encouraging people to not get wedded to screeners, because they're just not, they may be validated in research studies, but that doesn't mean that, in a clinic, people are actually going to feel comfortable talking with you, especially when it's at the front end of the visit. It's like the third thing is these very intimate questions about your relationships that people may not feel comfortable talking about at all.
Well, thank you for that. These are many challenges, and I'm sure others in the audience can relate. But definitely universal education does improve that whole person care. And lastly, what type of support does an organization need to implement and sustain universal education? What would support look like for a clinic?
So you need champions, and you need people who really, and often the people who are engaged in championing this issue are championing other issues as well. So really trying to find a few key people, not just one, but a few key people who really are going to prioritize moving this issue forward, that they can encourage others, how let people know how we're doing as a clinic, share stories, both, good and bad stories, when things went really well, and then, when things didn't go so well, and how can we change that in the future. And identify and address barriers and listen to others about what they find the barriers to be. So it's not just all on you, what are the barriers I'm seeing, but really soliciting that information from the rest of the clinic team. What problems are you running into? What's getting in your way? Not, how many cards did you hand out today, but really what got in the way of you being able to engage in this intervention. So that's sort of in the clinic. And then outside of that, the clinic, it's really developing and maintaining relationships with community-based organizations. And Futures Without Violence recommends, and it seems really helpful, to really formalize those relationships with a memorandum of understanding that you review annually and update, and have that not just be a paper process, but that you actually, and I really encourage clinic staff to go out into the community, because we tend not to, see where you're sending people, meet the people, listen to a presentation about, we actually brought in organizations to talk with our staff about what services they provided, and sort of words to the wise, and for us in terms of working with survivors. But get the clinicians and the clinic staff out of the clinic and into the community to learn about services. And a year can be a really long time. So you can have this beautiful MOU that looks great, and then, like I said, nobody answers the back office number. So really checking in, I think, more regularly, every couple of months. How is it going? Are referrals being completed? Are people engaging in care? And not just the stories with, it's sort of no data without stories, no stories without data. So the stories really motivate people, but the numbers reinforce. And when we're sending a lot of people, but they're not engaging, then there's something about the way we're doing, about the way we're doing the referral that isn't successful, and we need to look back at what we're doing. So I would say those, to me, are the main supports. And just somebody, also just like somebody to deal with the logistics, dumb things like you run out of cards, or you don't have the most up-to-date card. For example, they've just revised a lot of the cards in Spanish with a much improved cultural translation. So, having somebody who's just, their job is to make sure they're ordering the cards, having things in place, checking phone numbers, making sure resources are still real, exist, and are taking clients. And having a regular check-in process, like at your monthly staff meeting. Initially, we checked in monthly, and then every 3 to 6 months, to see just how are things going, have issues come up, do you have what you need, do you need additional training, are there people in your pod that haven't been trained, those kinds of issues.
Thank you. Yeah, I've definitely learned that having a champion can address a lot of these things, especially turnover, which is something that, I've learned that clinics are, frequently being impacted, especially during the pandemic, well, now post-pandemic. So now I'm going to transition over to Spanish. So ahora quiero escuchar de Rosa María, ¿por qué es importante que los proveedores de salud le den el recurso a todos los pacientes que pasan por sus puertas?
Bueno, no te escuché muy bien, Erika, pero yo creo que esa pregunta es para mí, ¿verdad?
Sí.
Es muy importante proporcionar los recursos, ya que es una manera de crear conciencia y educación tanto en nuestra comunidad como en las personas sobrevivientes de violencia doméstica. En las víctimas de violencia doméstica e incluso en las personas que dañan, puede ser una buena intervención, ya que a veces la persona que está pasando por violencia doméstica vive con miedo en muchos aspectos, desde miedo por no tener documentos legales, miedo a perder custodia de sus hijos, miedo a no poder sostenerse solos económicamente, miedo por el idioma, bueno, en muchos otros aspectos. Incluso muchas de las personas que son víctimas no saben o no son conscientes que están viviendo violencia doméstica. Por eso la importancia de proporcionar recursos. Proporcionar recursos es una forma de educar y apoyar a todas estas personas y a guiarles hacia la ayuda y hacerles saber que no están solas, que hay apoyo, que hay recursos, que hay educación y que todos podemos y merecemos vivir una vida digna sin violencia y merecemos una vida saludable tanto para nosotros como para nuestros hijos también.
Gracias, Rosa María. Entonces es importante proveer este recurso porque tal vez uno ni siquiera sabe si está en una relación abusiva o no sabe cuáles son esas banderitas rojas, ¿verdad? Y podemos mejorar la salud de esta manera.
Sí, así.
Ahora, sí. Ahora, Paula, si me pudieras compartir como tu perspectiva como promotora de salud de violencia doméstica, ¿por qué es importante incorporar la violencia de pareja íntima como parte del plan de bienestar y saber también el historial? ¿Por qué es importante?
Sí, Erika, yo creo que sabemos que la violencia de pareja íntima o violencia doméstica también, ¿verdad? Impacta la salud de la gente a largo plazo. Entonces, creo que cuando el proveedor sabe que esta persona ha sufrido violencia en alguna etapa de su vida, yo creo que es importante que esté muy pendiente a través de los años, cómo estar dando seguimiento a los cambios en la salud de esa persona y también dar recomendaciones, ¿verdad? Porque, por ejemplo, en una mujer viene la etapa de la menopausia, entonces es una etapa donde hay muchos cambios, ¿verdad? Entonces, ¿cómo si ya traemos arrastrando ese daño físico y emocional, cómo va a impactar a esa persona, ¿verdad? Y creo que también siento que hay una conexión entre nosotros como promotores y el personal médico, ¿verdad? Que estamos ahí para servir a la comunidad y siempre estar pendientes para ver qué es lo que hace falta, cómo le podemos apoyar. Y creo que una de las características es siempre saber escuchar, estar presentes, dar recursos. Entonces, son muchas de las cosas que tenemos que estar ahí poniendo atención, ¿verdad? Porque tenemos que escuchar a la comunidad y no nada más escucharlos, porque sabemos que puede haber un entrenamiento, ¿verdad? O muchos entrenamientos en las etapas cuando nos estamos preparando profesionalmente para servir a la comunidad, pero no nada más es el entrenamiento. Yo pienso que es la entrega, es el corazón, es poner todo tu ser en lo que estás haciendo, porque lo tienes que sentir y tiene que venir de adentro de tu corazón para poder lograr esa conexión. Entonces yo pienso que es un conjunto de cosas. Entonces estar preparado juntamente con la persona y lograr esa meta.
Sí, claro, muchas gracias por eso. Es decir, de que tiene que haber esa conexión entre el paciente y el doctor o el proveedor de servicio médico, ¿verdad? Y así se ve todo el historial y están incorporando el historial de esa persona para mejorar el bienestar de salud de esa persona, ¿verdad? Y de su
Correcto,
familia.
así es.
All right, well, this concludes our presentation for today. I am going to open it up if there's any questions for Erica, if there's any questions for Paula or Rosa. We'll be here if anybody has any questions or comments. Comments are always welcome. So there is a question in the chat, Erica. There's a question. I'm curious of if your practice integrated the CUES model during telehealth visits, and if so, what would healthcare providers be mindful of using it during a telehealth visit?
So that's a great question. I spent the entire pandemic outside of the country. So I was not in the clinic then, but I continued to work with Futures Without Violence, who the organization provided a lot of guidance for doing CUES interventions, continuing to do this work in the context of telehealth. So the issue is the same in terms of confidentiality, a little bit harder to determine. But again, this was a big issue for our clinic because we were seeing adolescents. So really helping them to sort through if they were actually in a private space, could they have a private conversation? Was there a better time to talk, etc. And of course, establishing any kind of rapport or trust, which is really hard to do face-to-face, it's even more difficult to do over a Zoom visit or a telehealth visit. So I think putting that up front, saying acknowledging that we don't really know each other and this is not an easy way to develop a relationship. And I'm going to be talking with you about some things that might make you feel uncomfortable, and it's totally up to you. Please feel free to tell me that you don't want to go there right now. You don't want to talk about it. That's not why you're here. Also facilitating the ability to forward, so you can send digital copies of the card. It's a PDF, so it's like a big sheet instead of a card. But we would send them after the visit, or add them to the after visit summary, so that the patient could access them. And if you have, again, with the issue of adolescents, we have partition charts, so that would go in the confidential section, so that the parent, who can also see some of their health records, couldn't see that even we'd had a conversation about, sometimes they don't even know that their kid is in a relationship, let alone in a relationship that might not be that healthy. But it is an additional challenge. And I think that post-pandemic, a lot of places are really hanging on to those televisits. It's a convenient way to see patients. It's convenient for patients as well. So I think we came up with ideas. We haven't had a lot of feedback about how they work. And unfortunately, I don't have direct experience because we weren't doing telehealth before the pandemic, and I got to miss out on all that. So, but I would really encourage you to take a look at the materials that Futures Without Violence has on there's an IPV Health and there's two IPV Health. I think there's one that's IPV Health and one that's IPV Health Centers. But they're on their websites, they have recommendations for telehealth.
And I will send that information. Futures created a clinical pathway for telehealth. So I will be sending that after this event later on this week, or probably Monday, with all the resources and where to get the safety cards and the websites that Erica's speaking about. Are there any other questions or comments? I'll let you guys think for a bit, but we're also going to be sending a post survey for those who attended this session and the previous session of what would you like to see next. What are the next steps? If you're interested in learning more, a particular section, or something that you would like us to expand on, So we're going to be sending that because we're here to support. We're here to serve the community and improve the overall health of our community, right? So are there any questions, comments? If not, we would be done because it's already 1 o'clock, and I also want to respect your time. I know everybody's super busy. We have a lot of things to do. So if there isn't any questions, we will end it here. Thank you so much for
Hey, Erica.
Oh.
I just want to say thank you, and it's really great hearing the different perspectives, not only from next door, but clinic, and then patients. So it was really amazing, and thank you for hosting this.
Thank you. Please provide the feedback to Dolores.
Yep, thank you very much. This was super helpful. I actually did have one more question now that I think about it. I was curious too for both the promotoras and for clinic staff, when you start to think about integrating this model, I know the teams themselves may have experienced trauma in their lifetime. So how do you address that going into a model like this?
I can speak on that because we actually, when we partnered up with the health center to even enhance their screening process, one of the things that we talked about as a team with the clinic champions is how do we address this? Because over 50% of their staff were survivors themselves. So we actually brought in HR and created some HR policies. There's actually, from Futures, they have a whole toolkit on domestic violence in the workplace. They have videos, case scenarios, recommendations for managers, supervisors. So I can also share that as well. But it is a good component to have on making sure that your HR policies support for your staff is also there. So making sure that you have, like, for example, we have our wellness, it's called EAP, where our staff are able to access therapy services, resources, if this is something that happens. So it's important to have a protocol for staff as well, and also where to refer them if this is something that triggers them. So even when we were providing training for domestic violence, we had these disclosures, like if you are in need of or something triggers you, because we know there could be survivors anywhere, we had staff available, advocates from our agency, to provide that support, individual support if needed.
Thank you, Erica.
All right. Are there any other questions? Thank you for the comments in the chat. Also, we're gonna email you guys. So if there's any questions, please feel free to email us at DV Health. I am putting it in the chat. If there's any questions that you may have, please email us and we can connect you. If we don't know the answers, we can connect you with Erica if need be, if there's specific questions, or if there are specific interests in regards to this topic.